One of the most severe complications following restorative rectal cancer surgery is anastomotic leakage, which occurs in up to 20% of patients. It is generally known that anastomotic leakage is associated with poor outcomes. However, we do not know the most effective treatment strategy for anastomotic leakage. Therefore, we aim to give an overview of the clinically applied treatment strategies and perform a comparative analysis between passive and active drainage amongst diverted patients. Of the included patients in the study, the majority underwent fecal diversion with passive drainage as a primary treatment strategy, while the minority underwent fecal diversion with active drainage or treatment without fecal diversion. Upon closer examination of the primary outcome, it was observed that stoma-free survival was low following salvage surgery. Notably, these patients exhibited the most adverse leakage characteristics at time of diagnosis, and they were more likely to experience severe symptoms. Stoma-free survival remained relatively high in patients treated without fecal diversion. However, these patients had more favorable leakage characteristics at time of diagnosis. In the final meshed analysis, we observed no statistically significant difference regarding stoma-free survival between passive and active drainage amongst diverted patients. However, it was evident that patients who received active drainage were more likely to requiring secondary salvage surgery. They also had a prolonged duration of hospitalization and were more frequently admitted to the intensive care unit. In conclusion, these findings represent real-world data on the treatment of anastomotic leakage following rectal cancer surgery. It remains uncertain whether vacuum drainage itself has a detrimental effect or if bias influences study outcomes. Nevertheless, it is evident that the treatment of anastomotic leakage is primarily tailored to specific patient and leakage characteristics.